Hello, this is Dr. Stephen Morris. I'm doing a lecture series for Anatomy and Physiology 2. Today the lecture will be on the cardiac system. Now, when I refer to the cardiac system, and many times in our discussions we'll refer to the cardiac system as the cardiovascular system, the two systems are intimately involved, and thus there is some significant overlap in the lecture material that we will have here in the cardiac system, along with the circulatory system when that lecture series begins as well. So please bear that in mind. As we start with the cardiac system, it's important to recognize that every cell relies on the surrounding interstitial fluid for oxygen, nutrients, and waste disposal. The composition of the interstitial fluid and tissue throughout the body is kept stable through a continuous exchange between the peripheral tissue and the bloodstream, namely the heart being the pump that supplies the blood through these tissue areas. The process and the concept of homeostasis we've discussed in detail in Anatomy and Physiology Part 1. So I know many of you already have an understanding of homeostasis. When we look at the cardiovascular system and the relationship in blood, we see that blood can help maintain homeostasis only as long as it stays in motion. If blood remains stationary, its oxygen and its nutrient supplies will quickly be exhausted, and its capacity to absorb waste will soon be saturated, and neither hormones nor the white blood cells can reach their intended target. So let's look at the functions of the cardiac system, and you will be responsible for knowing the functions of the cardiac system. All of the functions of the cardiovascular system ultimately depend on the heart. Unlike most other muscles, the heart never rests. This is an extraordinary organ, and it beats approximately 100,000 times each day, pumping approximately 8,000 liters of blood, enough to fill about 55-gallon drums, or about 8,800 quart-sized milk cartons. Blood flows through a network of blood vessels that extend between the heart and the peripheral tissue. We'll have a separate lecture that will go into detail more about the circulatory component of this system. However, those blood vessels can be subdivided into, number one, a pulmonary circuitry, which carries blood to and from the gas exchange surfaces of the lungs, and number two, the systemic circuit, which transports blood to and from the rest of the body. This is an illustration out of your textbook just demonstrating the two circuitries in which we talk about. Again, the pulmonary circuitry and the systemic circuitry, as the illustration shows. Pulmonary arteries and pulmonary veins are the primary vessels involved in transporting blood to and from the pulmonary system. And then the systemic circuitry, the aorta, is a large vessel that takes the blood away from the heart, and then multiple branches from the aorta distribute blood throughout the body at various locations. A basic overview of the cardiovascular system. Driven by the pumping heart, blood flows through separate pulmonary and systemic circuits. Each circuit begins and ends at the heart, contains arteries, capillaries, and veins. Think of the system as carrying two types of vessels, afferent vessels and efferent vessels. Blood is carried away from the heart by arteries, or efferent vessels, and returns to the heart by way of veins, or afferent vessels. Small, thin-walled vessels, called capillaries, interconnect at the smallest arteries and the smallest veins. Now, the roles of the capillaries are very important. The capillaries are the exchange vessels. Because they have these very thin walls, they permit the exchange of nutrients, dissolved gases, waste products between the blood and surrounding tissues. Despite this impressive workload, the heart is a small organ, roughly the size of a clenched fist. The heart contains 4 muscular chambers, 2 associated with each of the circuits. The atrium, the right atrium, a chamber or pleural atrium, receives blood from the systemic circuit and passes it to the right ventricle. The right ventricle referring to a little belly, which pumps blood into the pulmonary circuit. The left atrium collects blood from the pulmonary circuit and empties it into the left ventricle, which contracts, ejecting blood into the systemic circuit by way of the aorta. The ventricles, when the heart beats, the atrium contracts, and the ventricles contract. The two ventricles contract at the same time and eject equal volumes of blood into the pulmonary and systemic circuit. This is an illustration from your book demonstrating the location of the heart, as you can see, lying in the chest cavity. You can see it lies in an anterior position. You can see the structures that lie at the heart posterior, looking primarily at the tissue of the esophagus in cross-section, the lung branches, both the right and left pulmonary bronchus, which we'll discuss more when we go into the pulmonary system. Then you can also see the aorta, which actually arches out of the heart. And then you can also appreciate the pulmonary circuitry, the pulmonary arteries, and the pulmonary veins as they distribute into the parenchyma of the lungs. Also appreciate the position of the heart. It lies just posterior to the sternum, but again lies anterior to the esophagus, and then the good landmark for you to establish a relationship is to see the vertebrae, which lies obviously posterior in the chest wall. The location of the heart in the thoracic cavity is situated in the anterior part of the mediastinum, immediately posterior to the sternum. An anterior view of the open heart, as we saw in the last slide, showing the position of the heart in the major vessels relative to the lungs. In the superior view, again from the previous slide, the other organs in the mediastinum and the tissue of the lungs are removed to reveal blood vessels and airways. This illustration from your textbook demonstrates the pleural cavity, the pleural space that surrounds the cardiac muscle. It would be nice if you would bring out your textbook at this point so you can follow the next several slides and use your textbook and the illustration in your textbook to be able to visualize the pleural cavity. The pleural cavity and its relationship of the heart and the pericardial cavity is compared to a fist being pushed into a balloon. The great vessels and the arteries are connected to the superior end of the heart and attached to the base. The base sits posterior to the sternum at the level of the third costal cartilage, centered about 1.2 centimeters or 0.5 inches to the left. The inferior tip of the heart is the free apex. Now keep that in mind. When we talk about the pulmonary system and the lungs, you'll see that the apex of the lungs sit in a superior position. In the heart, the apex of the heart sits in an inferior position. The base of the heart sits posterior to the sternum at the level of the third costal cartilage, centered about 1.2 centimeters or 0.5 centimeters to the left. The inferior the inferior or pointed tip of the heart is referred to as the apex or the free apex of the heart. Actually, when the heart beats, the apex actually flips forward and actually strikes the anterior wall of the chest. That point can be seen clinically and is referred to as a point of maximal intensity. It's a diagnostic sign of cardiac enlargement when that point of maximum intensity changes to a more inferior location. You're not responsible for the point of maximum intensity for the purposes of this lecture, but it is a point of clinical reference that I thought it was important to mention. Now, the pericardial cavity, as you can see from the previous illustration, is basically where the heart is surrounded by a wall of tissue referred to as the pericardial cavity. It sits in the anterior portion of the mediastinum. The pericardium, which is the lining of the pericardial cavity, is called the pericardium. To visualize the relationship between the heart and the pericardial cavity, imagine pushing your fist toward the center of a large balloon. The balloon represents the pericardium, and your fist would represent the heart. The mediastinum, the region between the two pleural cavities, also contains the thymus, esophagus, and the trachea. The pericardium is lined with a delicate serous membrane that can be subdivided into visceral pericardium and parietal pericardium. Visceral and parietal pericardium actually cover the outer surfaces of the heart. The visceral pericardium, or the epicardium, covers the outer surface of the heart and adheres closely to it. The parietal pericardium lines the inner surface of the pericardial sac, which surrounds the heart. The pericardial sac, or a fibrous pericardium, which consists of a dense network of collagen fibers, stabilizes the position of the heart and is associated with vessels within the mediastinum. The pericardial cavity, this is a small space between the parietal and the visceral surfaces of the pericardial cavity. It normally contains about 10 to 20 cc's or 10 to 20 milliliters of pericardial fluid secreted by a pericardial membrane. The fluid acts as a lubricant, reducing friction between the opposing surfaces of the heart as it beats. There is a condition referred to as pericarditis. I'll briefly mention it at this point. In a subsequent lecture, you'll have a more detailed discussion about pericarditis. Pericarditis basically is inflammation in the pericardium that surrounds the heart. Pathogens can infect the pericardium, producing the condition referred to as pericarditis. The inflamed pericardial surfaces rub against one another, producing a distinctive scratching sound. Pericardial irritation, inflammation, also commonly results in increased production of pericardial fluid. In a condition referred to as cardiac tamponade, again, I'll mention it briefly here, but in a more detailed discussion, you will have a specific lecture about cardiac tamponade. Fluid which collects in the pericardial cavity may restrict the movement of the heart. The condition, called cardiac tamponade, can also be caused from a traumatic injury, such as a gunshot wound that produces bleeding in the pericardial cavity. Again, in a later lecture, you'll have more detail about cardiac tamponade. Superficial anatomy of the heart. There are 4 chambers easily identified in the superficial view of the heart. This illustration and gross slide of the heart is taken from your textbook. Please note the structures of the heart. You will be required in the laboratory portion of this course to be able to identify these structures both in the illustration and in a gross anatomy photograph. Speaking a bit about the specific anatomical regions of the heart, we'll start with the atria. The 2 atria have relatively thin muscular walls and are highly expandable, not expendable. When not filled with blood, the outer portion of each atrium deflates and becomes a lumpy, wrinkled flap. This expandable extension of an atrium is called the atrial appendage, or the auricle, or the ear of the heart, because it's reminded early anatomists of an external ear. You can appreciate this on the illustration shown here, and also on the gross anatomy slide shown here. The sulcus, the coronary sulcus, is a deep groove that marks the border between the atrium and the ventricles. The anterior interventricular sulcus and the posterior interventricular sulcus is shallower depression which marks the boundary between the left and the right ventricles. Sulci, the connective tissue of the epicardium at the coronary and interventricular sulci, generally contain substantial amounts of fat. In a fresh or preserved heart, this fat must be stripped away to expose the underlying groove. These sulci also contain the arteries and the veins that supply blood to the cardiac muscle. Now understand, the heart supplies blood in a pulmonary circuit and in a systemic circuit, but the muscle tissue of the heart itself also requires a blood supply as well. And again, the arteries and the veins that supply that blood to the cardiac muscle can be seen in the sulci. This is a cross-sectional view, an illustration of the heart wall. And it's important, again, for the purposes of your laboratory portion of this course, to be able to identify the structures as illustrated here in this photograph. The heart wall is basically divided into several layers. 3 distinct layers are what you will be required to identify. There's an outer layer referred to as the epicardium, a middle myocardium, and an endocardium. The epicardium is the visceral pericardium that covers the outer surface of the heart. This serous membrane consists of an exposed mesothelium and an underlying layer of loose connective tissue that is attached to the myocardium. The myocardium, or the muscular wall of the heart, forms the atria and the ventricles. This layer contains cardiac muscle, tissue, blood vessels, and nerves. The myocardium consists of concentric layers of cardiac muscle tissue. The atrial myocardium contains muscle bundles and wrap around the atrium and form a figure 8 as it passes through the interatrial septum. Superficial ventricular muscles wrap around the ventricles. Deep muscle layers spiral around in between the ventricles, forming the apex, again, which is the tip or the blunted tip of the heart lying in the inferior location. The inner surfaces of the heart, including those of the heart valve, are covered by an endocardium, a simple squamous epithelium that is continuous with the endothelium of the attached blood vessels. You have reviewed the histology of the cardiac muscle in A&P Part 1. Again, you will be required as a part of the laboratory study to be able to clearly identify structures associated with the histological slide of cardiac muscle. As you remember, cardiac muscle differs from skeletal muscle in that it not only contains striations, but it also contains structures referred to as intercalated discs. These discs act as intercellular connections between cardiac cells. Cardiac cells are under a significant amount of stress when they beat, and thus the intercellular connections must be strong. The intercalated discs are represented here. Also, you may note the branching of cardiac muscle. Instead of smooth, cylindrical, longitudinal bundles, these bundles branch, which differs from skeletal muscles. Also, you notice the pattern of striations that is similar to skeletal muscle. However, the primary differences when we talk of cardiac muscle is the branching and the intercalated disc. Cardiac muscle cells are interconnected by these intercalated discs. The intercalated discs, the interlocking membranes of adjacent cells, are held together by desmosomes and are linked by gap junctions. If you remember back in A&P Part 1, desmosomes and gap junctions are other forms of connections between cells. Intercalated discs convey the force of contraction from cell to cell and also help to propagate the action potentials. The internal anatomy and organization of the cardiac system. Following slides will demonstrate some major landmarks and structures visible in the interior surface of the heart. In a sectional view, which will follow, you can also see that the right atrium communicates with the right ventricle and the left atrium with the left ventricle. The atria are separated by interatrial septum or wall, and the ventricles are separated by a much thicker interventricular septum. This is an illustration from your book, again representing structures which you will be required to identify as a portion of the laboratory portion of this course. Briefly, I will identify some of the structures we just discussed. The arrow now is pointing at the right atrium. The right atrium communicates with the right ventricle. Blood from the right ventricle is passed into the pulmonary circuit via the pulmonary trunk, which leads into the pulmonary arteries. This is the only artery in the body that carries deoxygenated or unoxygenated blood. The pulmonary arteries will supply blood to the tissue of the lung, which will branch into smaller capillaries where exchange will take place between unoxygenated and oxygenated blood. It is at this capillary level that exchange of air, oxygen, will enter into the system, and then that blood will be transported back into the heart via the pulmonary veins. This demonstrates the left pulmonary veins. There are also right pulmonary veins as well. These veins are the only veins in the human body that carry oxygenated blood. Blood will then return from the lungs into the left atrium via the pulmonary veins. Blood will then move from the left atrium into the left ventricle, the large muscular left ventricle. Again, you can appreciate the interventricular septum that we had alluded to in an earlier slide. And then the left ventricle will contract and push blood through the aorta into the systemic circuitry. There are a number of branches that come off of the aorta. The aorta later divides at the descending aorta into major vessels as well, but this will be discussed in more detail when we discuss the circulatory system. This is a gross anatomy slide of the heart. Again, it represents the same structures that I've talked about previously. For the purposes of the laboratory examination, again, you will have to identify the structures as labeled on this slide. I will not go into any more detail at this point because some of the structures we'll still need to discuss. Now, the heart is composed of a number of valves that are designed to allow blood to leave from one chamber into the other, but also to prevent backflow of blood as well. Each of the septums is a muscular partition. The atrioventricular, or the AV valves, fold fibrous tissue. These are folds of fibrous tissue that extend into the openings between the atria and the ventricle. These valves permit blood flow into one direction only, from the atrium into the ventricle. The right atrium receives blood from the systemic circuit through two great veins, the superior vena cava and the inferior vena cava. You should be able to identify these structures on the previous illustration and a gross anatomy slide. Recognize we will have a much more thorough discussion about the superior vena cava and the inferior vena cava when we discuss the circulatory system. The superior vena cava, which opens into the posterior and superior portions of the right atrium, deliver blood to the right atrium from the head, neck, upper limbs, and chest. The inferior vena cava, which opens into the posterior and inferior portions of the right atrium, carries blood to the right atrium from the rest of the trunk, the viscera, and the lower limbs. The coronary veins of the heart return blood to the coronary sinus, a large, thin-walled vein that opens into the right atrium inferior to the connections with the inferior vena cava. The foramen ovale, the opening of the coronary sinus, it lies near the posterior edge of the intraatrial septum. From about the 5th week of embryonic development until birth, the foramen ovale is an oval opening that penetrates the interatrial, if I can say that word, interatrial septum, which connects the two atria. The foramen ovale permits blood flow from the right atrium to the left atrium while the lungs are developing before birth. Now recognize the importance of this structure. As the lungs of the infant or the embryo are developing, they are not functional. And because of this, even though the baby's heart is functioning and pumping blood to the rest of the system of the baby, of the developing embryo, the lungs cannot provide oxygenated blood. Thus, blood from the mother, which is oxygenated, has to enter into the fetal circulation. Blood from the mother enters into the right atrium. But there is no need for the blood to enter into the right ventricle because the right ventricle pumps blood into the pulmonary circuitry. The developing embryo does not have a functional pulmonary system. So thus the foramen ovale allows a shunting of blood from the right atrium into the left atrium, then into the left ventricle, and then out to the embryonic systemic circulation. This shunting of blood is invaluable for the survival of the embryo because this is the only way that the embryo will receive oxygenated blood. At birth, the foramen ovale closes, and the opening will be permanently sealed off, typically within 3 months of delivery. It becomes the fossa ovalis, which is basically just a flat tissue-filled structure. It's a small, shallow depression, and the site persists even in the adult heart. If the foramen ovale does not close, blood will flow from the left atrium into the right atrium rather than the opposite way, because after birth, the blood pressure in the left side of the heart is higher. Thus, blood pressure in the pulmonary circuit is lower than what we see in the systemic circuit. A shunt from the left side of the heart to the right side of the heart causes oxygenated blood to mix with unoxygenated blood in the right atrium, thus decreasing the amount of oxygenated blood that would be available to enter into the systemic circuitry. The posterior wall of the right atrium and the interatrial septum have smooth surfaces. In contrast, the anterior atrial wall and the inner surface of the auricle contain prominent muscular ridges called pectinate muscles, or the other term used for that is musculi pectinati. The right ventricle, blood travels from the right atrium to the right ventricle through a broad opening bounded by 3 fibrous flaps. These flaps are referred to as cusp and are part of the right atrioventricular valve, also known as the tricuspid valve. The free edges of each cusp attach to the tendinous connective tissue fibers called chordae tendineae. Chordae tendineae basically are fibers that originate at the papillary muscles. The papillary muscles are conical muscular projections that arise from the inner surface of the right ventricle. The right AV valve closes when the right ventricle contracts, preventing a backflow of blood into the right atrium. Without the chordae tendineae, the cusp would be like swinging doors that would permit blood from flowing in both directions. Another structure that will be important for you to be able to identify is the trabeculae carnae. The internal surface of the ventricle contains a series of muscular ridges, the trabeculae carnae. Another structure, referred to as a moderator band, is a muscular ridge that extends horizontally from the inferior portion of the interventricular septum and connects to the anterior papillary muscle. This ridge contains a portion of the conducting system and an internal network that coordinates the contraction of cardiac muscle and cells. The moderator band delivers the stimulus for contraction to the papillary muscles so that they begin tensing the chordae tendineae before the rest of the ventricle contracts. Pulmonary valves. The superior end of the right ventricle tapers to a conus arteriosus, or a conical pouch, which ends at the pulmonary valve, or the pulmonary semilunar valve. The pulmonary valve consists of 3 semilunar or half-moon-shaped cusps of thick connective tissue. Blood flowing from the right ventricle passes through this valve and enters the pulmonary trunk at the start of the pulmonary circuit. The arrangement of the cusps prevents backflow of the right ventricle as it relaxes. This is a superior view, cross-sectional view, of the valvular system of the heart. Superiorly, as you can see, at the right atrium, the tricuspid valve opens. The right AV valve. This is the left AV valve, or a bicuspid valve. And these are the pulmonary valves. Again, you can see this is a 3-leafed or 3-cusp valve. And then the aorta valve, which is also seen in this picture, also a 3-cusp valve. Cross-sectionally, again, you can see the large, thick muscular wall of the ventricle. You can see the region that's referred to as the trabeculae carnae. You can also see the conical-shaped papillary muscle. You can see the chordae tendineae, basically the little cords or strings that lead from the conical-shaped papillary muscle. And this is basically the cusp of one of two valves that lead from the atrium. As you can see, this gives an appearance of a parachute. This being the parachute, and these are the cords. You will be responsible for identifying these structures in the laboratory portion of this course. Pulmonary vein circulation. Once in the pulmonary trunk, blood flows into the left pulmonary arteries and the right pulmonary arteries. These vessels branch repeatedly within the lungs before supplying capillaries where gas exchange occurs. The left atrium. From the respiratory capillaries, blood collects into small veins and ultimately unites to form 4 pulmonary veins. Remember, the pulmonary veins are structures that now will bring oxygenated blood from the lungs to the heart. The posterior wall of the left atrium receives blood from 2 left and 2 right pulmonary veins. The left AV valve, also known as the mitral valve, like the right atrium, the left atrium has an auricle, the ear. A valve, the left AV valve, or bicuspid valve, guards the entrance of the attached ventricle. As the name bicuspid valve implies, the left AV valve contains a pair, not a trio, of cusps, as seen in the previous illustration. Clinicians often refer to this valve as the mitral valve because it gives the appearance of a bishop's hat. The left AV valve permits blood from the left atrium into the left ventricle. Again, the illustration demonstrates to you the 2 valves, the bicuspid valve that opens. The left ventricle. The right and left ventricle contains equal amounts of blood. An important thing to note. The left ventricle is much larger than the right. However, it has a much thicker wall. The thick muscular wall enables the left ventricle to develop pressure sufficient enough to push blood through the large systemic circuit, whereas the right ventricle needs to pump blood at a lower pressure only at about 15 centimeters or 6 inches to and from the lungs. Again, this illustrates the thick muscular wall of the heart, especially when we talk of the left ventricle of the heart. The internal organization of the left ventricle generally resembles that of the right ventricle, except the absence of the moderator band. The trabecular carnae are prominent, and a pair of large papillary muscles tense the chordae tendineae and brace the cusp of the AV valve to prevent backflow of blood into the left atrium. Again, there's a pair of valves, papillary muscles. Only one is illustrated in this photograph, the trabecular carnae, and again the thick muscular wall of the left ventricle. The aortic valve. Blood leaves the left ventricle by passing through the aortic valve or the aortic semilunar valve into the ascending aorta. The arrangement of the cusp in the aortic valve is the same as in the pulmonary valve. Here is the illustration of the valve closed in the aorta. The aortic sinus, which is a sac-like dilatation at the base of the ascending aorta, are adjacent to each of the cusps. The sacs are called aortic sinus and prevent individual cusps from sticking to the wall of the aorta when the valves open. Now, the right and the left coronary arteries, the coronary arteries deliver blood to the myocardium, to the heart muscle itself, originate at the aortic sinuses. Once the blood has been pumped out of the heart into the systemic circuit, the aortic valves prevent backflow into the left ventricle. From the ascending aorta, the blood flows through the aortic arch and then into the descending aorta. But let me regress for just a moment. At the right and left coronary arteries, after the blood is pumped from the left ventricle into the systemic circuitry via the aorta, the aortic valve will then close. Some of the blood will occur in a backflow motion, push against the aortic valve, and the pressure from that will allow blood to go into the coronary arteries, which are in the aortic sinus, which are at the base of the aorta. This is how the coronary arteries fill with blood. It is actually the backflow pressure from after the blood has been pumped out of the left ventricle that allows these coronary vessels to fill with blood. Now, as previously noted, the ascending aorta, blood will flow through the aortic arch, will branch to several areas which come off of the aorta, and then blood will also flow into the descending aorta. This will feed the lungs, gastrointestinal tract, and lower extremities. The pulmonary trunk is attached to the aortic arch by the ligamentum arteriosum. This is a ligament that is a remnant of an important fetal blood vessel that was once linked to the pulmonary and systemic circuit. This is a cross-sectional illustration of the heart muscle. I probably should have shown this earlier, but as you can appreciate, the thin wall of the left ventricle, the very thick wall of the left ventricle, versus the thin wall of the right ventricle, shown better in this cross-sectional illustration above, the left ventricle and the thinner walled right ventricle. You can appreciate the trabeculae carneae. You can also appreciate here the sulcus, the interventricular sulcus, again filled with fat. Blood vessels, coronary arteries, coronary veins are usually inside this sulcus. Right ventricular contraction. The lungs are close to the heart, and the pulmonary blood vessels are relatively short and wide. The right ventricle normally does not need to push very hard to propel blood into the pulmonary circuit. The wall of the right ventricle is relatively thin. In the sectional view that we just looked at earlier, it resembles a pouch attached to a massive wall of muscle, the left ventricle. When it contracts, the right ventricle acts as a bellow, basically squeezing blood against the thick wall of the left ventricle. This mechanism moves blood very efficiently with minimal effort. It also develops relatively low pressure. The comparable pumping arrangement would not be suitable for the left ventricle because 6 to 7 times as much force must be exerted on the blood around the systemic circuitry as around the pulmonary circuitry. The left ventricle has an extremely thick muscular wall and is round in cross-section. Again, this is the thick muscular wall of the left ventricle. Now, when the left ventricle contracts, we see the distance between the base and the apex will decrease. Literally, the heart will shorten. The diameter of the ventricle chamber also increases. The force generated are quite powerful, more than enough to open the aortic valves and to eject blood into the ascending aorta. Again, at the time of contraction, you will see the circumference of the heart in this chamber will significantly decrease when it squeezes, but you'll also see a shortening. This muscle will basically push up or pull up, ejecting the blood through the aorta. When we discuss the conduction system in the heart, you'll see where the electrical conduction actually begins at the apex of the heart. Even though it's transmitted from a superior location, the conduction actually begins at the base of the heart and radiates up. Thus, you'll see why the heart shortens. Contractions actually start at the apex of the heart instead of at the top to push the blood through the aorta. As the powerful left ventricle contracts, it also bulges into the right ventricular cavity. This dual action improves the efficiency of the right ventricle. Individuals whose right ventricular muscle has been severely damaged may survive because the contraction of the left ventricle helps push blood into the pulmonary circuitry. This is important for cardiologists when they evaluate a person that has suffered a right myocardial infarction or a right-sided heart attack that significantly damages the right ventricle. As long as the left ventricular function is preserved, the person will probably be able to survive the heart attack with minimal residual. Valvular heart disease. Again, this is a condition that will be discussed in more detail in a subsequent lecture. But basically, for valvular heart disease, serious valve problems can interfere with cardiac function. If valve function deteriorates to the point at which the heart cannot maintain adequate circulatory flow, symptoms of valvular heart disease will appear. Congenital malformations may be responsible for many causes of these conditions, and they develop after carditis, so infectious attacks, infectious endocarditis, may also be a cause. This infection can lead to significant inflammation in the heart muscle itself, and thus will lead to abnormalities in the valvular system as well. We will discuss some specific congenital abnormalities at a later lecture. However, for the purposes of this exam, and for this lecture, we will leave it as a general category of valvular heart disease. Now, in inflammatory heart disease, one relatively common cause of carditis is rheumatoid or rheumatic fever. An acute childhood reaction to the infection typically caused from streptococcal bacteria. Valve problems serious enough to reduce cardiac function may not appear until 10 to 20 years after the initial infection. The resulting clinical disorder is known as rheumatic heart disease. Rheumatic fever, classic cases of rheumatic fever, have been less common in the United States owing it to readily available antibiotic therapy. However, failure to complete the full course of antibiotic therapy may result in increased risk of developing carditis and subsequently rheumatic heart disease. We will next begin to talk about the conduction system of the heart, and this will be done in two parts. A general overview will be given as a part of this lecture, but a subsequent lecture will be given specific to address the cardiac conducting system and also to go over some specific arrhythmias. This will be included in a part of your laboratory material. In the conduction system of the heart, we will describe the SA node, or the sinoatrial node, otherwise known as the pacemaker of the heart. As you can see, it is located in the right atrium of the heart. We will also describe the function of the atrioventricular node. This is also located in the right atrium, the base of the right atrium of the heart. Also the conducting branches, the bundle branches, and the Purkinje fibers. These are all involved in the conduction system of the heart. These illustrations are taken from your book and basically gives you an overall view of the electrical activity that comprise the cardiac cycle of the heart. Electrical stimuli to the SA node, or the pacemaker of the heart, distributes the electrical activity to the conducting system of the heart, which will include the AV node, the bundle branches, and the Purkinje fibers, which will trigger stimulation of contraction in the cardiac cycle. The purpose is to maintain blood pressure and blood flow. It generates electrical activity, which we can measure and see on a strip, which generates electrical activity that can be recorded on a machine called an electrocardiogram and prints out a rhythm strip, or an illustration referred to as an ECG or an electrocardiograph. The electrical activity and the beating of the heart produce specific sounds referred to as heart sounds. Again, for the purposes of this lecture, we will keep it general. However, on subsequent labs, a specific illustration and demonstration of cardiac heart sounds will be given to you. The conduction system begins with the SA node located in the wall of the right atrium. The atrioventricular node, which is located at the junction between the atria and the ventricle, and then the conducting cells, which interconnect the two nodes and distribute contractile stimuli throughout the myocardium. The conducting cells of the atrium are found in the internodal pathway, which distribute the contractile stimuli to the atrial muscle cells and the impulse that travels from the SA node to the AV node. The importance of these pathways in relying on a signal, the AV node, remain in some dispute because the impulse can also spread contractile cells to contractile cells, reaching the AV node at about the same time as an impulse that transverses the internodal pathway. The ventricular conducting cells include those in the AV bundle and the bundle branches, as well as the Purkinje fibers, which distribute the stimuli to the ventricular myocardium. Now, the Purkinje fibers in the ventricular conducting cells include those in the AV bundle and the bundle branches, as well as the Purkinje fibers, which distribute the stimuli to the ventricular myocardium. This illustration is taken from your book, but gives an excellent representation of how the electrical activity is distributed across the myocardium. Again, in step 1, the SA node activity, atrial activation will begin at this point. This, again, the SA node, sinoatrial node, is referred to as the pacemaker of the heart. Once stimulus is generated from this point, you can see the spread of the electrical activity, first affecting the atrial portions of the heart. Starting at a superior location, contraction and shortening of the heart will begin. Remember, the blood has to be pushed from this chamber inferiorly into the left and right atriums. As you can see in step 3, the atrial contraction has begun. Again, blood has been forced into the ventricular chambers, both on the left and on the right. Electrical activity continues through the bundle branches in step 4. So the impulses travel along the interventricular septum within the branches of the muscle and then will extend to the Purkinje fibers. As this electrical activity extends into the Purkinje fibers, you will then begin to see contraction of the ventricles beginning in an inferior location, moving to a more superior location, causing again a shortening of the heart muscle and a pushing of blood from the right atrium. The blood is being pushed into the pulmonary circuitry. From the left ventricle, blood is being pushed out of the aorta. The SA node contains the pacemaker cells which establish the heart rate. The SA node is also known as the cardiac pacemaker or the natural pacemaker. The SA node is connected to a larger AV node by internodal pathways in the atrial wall. Conduction of action potential, it takes only 50 milliseconds for an action potential to travel from the SA node to the AV node along these pathways. Along the way, conducting cells pass the stimuli to contractile cells of both atria. The action potential then spreads across the atrial surface by cell-to-cell contact. The stimulus affects only the atria because the fibrous skeleton isolates the atrial myocardium from the ventricular myocardium. The AV node, the relatively large AV node, sits within the floor of the right atrium near the opening of the coronary sinus. The rate of promulgation, or the impulse, slows as it leaves the internodal pathway and enters the AV node because the nodal cells are smaller in diameter than the conducting cells. The AV node conduction, the connection between the nodal cells, are less efficient than those between the conducting cells at relaying the impulse from one cell to another. As a result, it takes about 100 milliseconds for the impulse to pass through the AV node and enter the AV bundle. A delay in impulse at the AV node is important because the atria must contract before the ventricles do. Otherwise, the contraction of the powerful ventricles will close the AV valve and prevent blood from flowing from the atria into the ventricles. Because there is a delay, the AV node, the atrial myocardium, completes its contraction before the ventricular contractions begin. In ventricular tachycardia, the cells of the AV node can conduct impulses at a maximum rate of 230 per minute. Since each impulse results in ventricular contraction, this valve is the maximum normal heart rate. Even if the SA node generates impulses at a faster rate, the ventricles will still contract at a rate of 230 beats per minute. This limitation is important because the mechanical factors discussed later begin to decrease the pumping efficiency of the heart at a rate of about 180 beats per minute. Ventricular tachycardia, rates above 230 beats per minute, occur when the heart or the conducting system has been damaged or stimulated by drugs. As ventricular rates increase toward their theoretical maximum limit of 300 to 400 beats per minute, pumping efficiency becomes dangerously, if not fatally, reduced. Bradycardia and tachycardia. A number of clinical problems are a result of abnormal pacemaker function. Bradycardia, slow in conduction condition, the heart rate is slower than normal, whereas in tachycardia, swift, it indicates that it's a faster than normal heart rate. These are relatively terms, and in clinical practice, the definitions vary with normal resting heart rate of the individual. The bundle of His. The AV bundle branches, and Purkinje fibers, the interconnection between the AV node and the AV bundle are also called bundle of His, is the only electrical connection between the atria and the ventricles. Once an impulse enters the AV bundle, it travels to the interventricular septum and enters the right and left bundle branches. The left bundle branch, which supplies the massive left ventricle, is much larger than the right bundle branch. Both branches extend toward the apex of the heart, turn, and then fan out deep to the endocardial surface. As the branches diverge, they conduct impulses to the Purkinje fibers. I again encourage you to go back to the previous slide that we looked at earlier, which shows the steps of conduction. Now, ectopic beats. If abnormal conducting cells or ventricular muscle cells begin generating action potentials at a more rapid rate, the impulses can override the SA or the AV node. The origin of these abnormal signals are called ectopic beats, or out-of-place pacemaker. The effects of ectopic beats. The activity of an ectopic pacemaker particularly or completely bypasses the conducting system, disrupting the timing of ventricular contractions. The result is a dangerous reduction in the efficiency of the heart. Such conditions are commonly diagnosed with the aid of an electrocardiogram. This is an illustration of an electrocardiogram. As you can see, a number of electrical conducting strips or electrodes are placed on an individual's chest wall. From the placement of these electrodes, the electrical pattern of the heart can be measured and illustrated in an electrocardiograph. Each of these wavy lines that are generated here represent a specific function of the heart. And we will go into more detail about what each of these patterns mean later in this lecture. Again, this is representative of the cardiac cycle, demonstrating electrical stimuli from the SA node, distribution of that electrical activity through the conducting system, resulting contraction of cardiac muscle, and also resulting cardiac relaxation. Again, the purpose of this cycle is to generate blood pressure and blood flow. The movement or dynamic actions of the heart generate specific sounds referred to as heart sounds. This is the pattern of a typical electrocardiograph, also referred to as an EKG or an ECG. As a portion of your lab, we will go through some specific electrical patterns of the heart, both normal patterns and abnormal patterns. The first representation here on the EKG is of a P wave. P wave represents atrial depolarization or atrial contraction. The QRS complex represents ventricular contraction. As you can see, this is the most prominent wave on the EKG. It is the most prominent wave because the myocardium of the ventricular system, specifically the left ventricle, contains more mass than any of the other chambers of the heart. Thus, it takes longer for electrical activity to pass through that muscle. It generates more force, and so it is a dominant waveform on the EKG. The last wave that you see is referred to as the T wave. The T wave represents ventricular repolarization or ventricular relaxation. Ventricular depolarization or ventricular contraction by the QRS complex, and resulting ventricular repolarization or relaxation represented by the T wave. Let us regress back to the P wave. The P wave generates a wave with atrial depolarization or atrial contraction. As you see, there is not a wave that represents atrial repolarization as we see a wave generated with ventricular repolarization. The reason for that is because of the dominant ventricular waveform. There is atrial repolarization, but the waveform is hidden in this dominant ventricular contraction. Each of these waveforms takes a specific period of time to occur. These periods of time can be measured in the forms of segments. As you can see, there's a PR segment, P wave to R, and there's also a QRS interval or QRS segment for ventricular depolarization, and then there's also an ST segment. The specifics I will not go into at this point. However, in your laboratory study, I will show you techniques by which you can measure these waveforms. Again, the P wave, the small P wave, accompanies the depolarization of the atria. The atria begins contracting about 100 milliseconds after the start of the P wave. The QRS complex appears as the ventricle depolarizes. This is a relatively strong electrical signal because the ventricle muscle is much more massive than that of the atrium. It is also a complex signal, and it's part because it incorporates the atrial repolarization as well as the ventricular depolarization. The ventricles begin contracting shortly after the peak of the R wave. Again, small P wave accompanies the depolarization of the atria. The atria begins contracting about 100 milliseconds after the start of the P wave. The QRS complex appears as the ventricle depolarizes or contracts, a relatively strong electrical signal because the ventricle muscle or ventricular muscle is much more massive than that of the atrium. The T wave. The smaller T wave indicates ventricular repolarization. You don't see a deflection corresponding with the atrial repolarization because it occurs while the ventricles are depolarizing and the electrical events are masked by the QRS complex. The PR interval extends from the start of the atrial depolarization to the start of the QRS complex. Ventricular depolarization rather than to R because the abnormal EKG, the peak can be difficult to determine. Extensions of the PR interval into more than a 0.2 second can indicate damage to the conducting pathway or the AV node. Again, I will show you during the laboratory portion of this course how to measure this interval, this PR interval. And again, we will review the significance of a delay in the conduction pattern. Always it is indicative of cardiac damage. QT interval. The QT interval indicates the time required for the ventricles to undergo a single cycle of depolarization and repolarization. It is usually measured from the end of the P wave to the R wave, the interval rather than the bottom of the Q wave. The QT interval can be lengthened by conduction problems, coronary ischemia, myocardial damage. A congenital heart defect that can cause sudden death without warning may be detectable as a prolonged QT interval. The electrocardiogram, as I showed you in a previous illustration, analyzes it is used for analysis of cardiac conduction activity and is useful in detecting and diagnosing cardiac arrhythmias and abnormal patterns of cardiac electrical activity. Momentary arrhythmias are not inherently dangerous. About 5% of healthy population experiences a few abnormal heartbeats each day. The clinical implications of this problem, however, when arrhythmias reduce the pumping efficiency of the heart. Again, in subsequent lectures, we will go through some of these significant arrhythmias. We'll discuss this briefly here now. Serious arrhythmias may indicate damage to the myocardium, injuries to the pacemakers or the conduction pathway, exposures to specific drugs, or variations in electrolyte composition and extracellular fluid. If you remember from A&P Part 1 when we talked of ions, if you remember, sodium and potassium are important ions in electrical conduction, as is calcium and as is manganese. Abnormalities in any of these electrolytes can lead to serious arrhythmias and may lead to abnormal conduction patterns in the heart. Other causes can be from acute myocardial infarctions, which cause damage to the heart muscle itself and also may cause damage to the electrical activity or the electrical conduction, and subsequent arrhythmias will occur. And as stated, exposure to a number of cardiotoxic drugs and or stimulants can lead to serious arrhythmias as well. Cocaine, for example, is a powerful cardiac stimuli that can cause significant arrhythmias and even cardiac death. These illustrations, again taken from your book, demonstrate the circulation provided by the coronary arteries. As you can see, they feed from branches of the aortic arch. As blood is being pumped from the left atrium of the heart into the systemic circulation, upon relaxation, portions of the blood begins to regurgitate back into the area of the heart. The valves prevent significant regurgitation of blood. When the valves close, the aortic sinuses fill with blood, which allows blood to then pass into the coronary vessels. This is another illustration of the vascular system or coronary circulation of the great vessels. For the purposes of laboratory examination, you will be asked to identify several of these key veins in the circulation. I will illustrate them to you in other photographs. This is an imaging, a radionucleotide imaging of the heart, a percentine thallium scan, which is used to inject a radioactive substance into the heart, which actually will clearly show up on an imaging scan to look at the circulatory pattern of the coronary arteries. If there is evidence of obstruction, then obviously the vessels distal to the point of obstruction would not light up. This ends the first part of the cardiovascular lecture.